Mm.
Good morning, good afternoon, and good evening to all of you peers and allies around the world. We are happy to have you today. If you can mute your microphones so that your background noise will not interrupt us. And Ashwin, maybe you can mute anyone that has background noise.
Okay.
I'd like to welcome people from all around the world to our third interactive global recovery dialogue. I am Nancy Dudley, a consultant to the Colombo Plan and a member of the U.S. State Department's Global Recovery Working Group. And today's event is the third of what will be a monthly global recovery dialogue. And this event and our upcoming dialogues, which we have planned for April and May, are part of an overall soft launch, which is leading up to the official launch of the Global Recovery Network in June of 2024 at the Art of Healing Conference in Greece. So the Global Recovery Network, which we refer to as GRN for short, is a new global entity. And our members include both persons in recovery and also those who identify as allies of recovery and support and promote recovery in their respective communities. The GRN is a global platform that's supported by a consortium of international organizations, many of which are represented today. And our mission is to promote a universal understanding of recovery and the diversity of ways in which recovery can be successfully practiced. And our GRN website is under construction and it'll be launched in June, so stay tuned for that. I'd like to get started today by introducing and welcoming Michael Botticelli, who is our facilitator. Michael is the chair of the Global Recovery Network and is the former director of the Office of National Drug Control Policy under President Barack Obama. And our presenter for today is Dr. Hendrée Jones, who is a clinical psychologist and a professor at the University of North Carolina School of Medicine. Dr. Jones has so many attributes on her resume, but I'll just mention that she is an internationally recognized expert on women and children's addiction treatment. And she is also the newly named chair of the Global Women's Network on Treatment and Recovery. And today, Hendrée will be speaking on harm reduction in the context of recovery. So Hendrée, I will turn it over to you and the floor is yours to get started.
Thank you so much, Nancy and Michael Botticelli and Ashwin for inviting me here today to have a conversation. My job, I see, is to kind of share some of the history of harm reduction. And this was actually something that was new to me. And I had shared a book that I read and some other information that I had read with Nancy, and Nancy's like, you should talk about this. So that is how I came to be with you all today. So let me share my screen because I have a couple of slides. So what we'll do is I will share some slides and then I'm going to turn it over to Michael to facilitate our conversation. And we have a couple of questions to set off the occasion of our conversation in our dialogue. And so I wanted to really, I think one of the most important things to kind of set this conversation is really defining what harm reduction is. And it has been defined in so many different ways. And so these are some of the original definitions of harm reduction. And as you can see on the slide, it really came out of a set of really practical strategies. What are those things that we can do to help keep people alive? And the history of the harm reduction really came out of the HIV/AIDS and that intersection with injecting drug use. And so the idea of having these practical strategies that could really stop harm and to keep people alive and able to function better. It also, within its roots, because there were so many people that were activists that were working so hard to get attention and treatment for those that had HIV or AIDS, that were often, if you were an injection drug user, were completely excluded from treatment, often turned away. And so it really, this movement became a social justice movement with the fundamental aspect of it being, how do we ensure we have rights for people? And I wanted to put this little picture in here of the Chicago Recovery Alliance. This is an example of anypositivechange.org. So the director of this, sorry, I need to look at this. Okay, so the director of this program in 1992, David Bigg, defined harm reduction as any positive change as a person defines it for him or himself. So you can really see even the word recovery at the same time with harm reduction. So from the very beginning, we have this, this intersection of harm reduction and recovery. People have also described harm reduction as love, 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 as radical acceptance, radical empathy for people. And I also want to share that harm reduction has tried to meet people where they are. So not to exclude people and say you are not worthy of treatment, you are not worthy of services, but let's have a conversation where you are, what positive change can we help you enact for yourself, what's important to you, and then hopefully how we can move you along that continuum of change. And so let's see, what else do I want to say? Okay, so here we are. So here's a little bit of history with harm reduction, and I do not have the corner expertise on this history of harm reduction, nor am I a harm reduction expert in any way. Again, this is a facilitation, this is some information. So in 1984, there was a recognition of HIV and AIDS. We knew that this was an illness, a disease that was happening for people that were gay and bisexual men in particular. And there was also an intersection with those that were injecting drugs. And so in the 1980s, there was a woman, Sheila Murphy, who was in the California Bay Area. And in 1981, she had a study that was really looking at teenagers in the kind of punk rock scene. And she was trying to understand their behavior and how she could modify their behavior to have better pro-social behaviors. And when she was hanging out at these punk rock clubs, one of the things that she was told about was needles and works behind one brick in a brick wall. And so she watched teenagers come use, like they would bring their own drugs, but they would use the same needle and the tourniquet over and over again. And she became incredibly frightened that these children were going to die of AIDS because she knew that it could be acquired through injection drug use. And so she really started a movement, got a number of people together, public health experts, physicians, even some other public policy people, and was like, what can we do? And that's really where they thought about like UV light to kill HIV. They went through hydrogen peroxide. There were a whole bunch of different things that they thought about, and they ended up with bleach because it was cheap, it was accessible. And so that's really how we have like the bleach protocols for our needles. And then in 1986, the international harm reduction movement was started. And one of the things that I found that was so interesting about this was in Liverpool, England, a needle exchange was set right across from the methadone clinic. So there you could have people maybe that weren't ready for treatment, but then when they were ready for treatment, could go right to the methadone clinic. Or if they had a return to use, that they were using the needle exchange to help keep themselves as healthy as they could. And then, so again, we've got this really interesting intersection of people that are activists that are trying to do things to keep people alive, to try and overcome the stigma and the fear and the hatred of HIV and AIDS and people who have this disease. You've had the additional stigma with people that were injecting drugs or people that were using drugs that were actually turned away from treatment. So there are many examples of people that had been injection drug users, and if they had HIV or AIDS, the treatment programs, the drug treatment program said, we can't treat you. We're too scared of you. We're not going to do that. So again, just that intersection that I think is so incredibly important for us to understand. And I also want to read a quote that Maya Solvitz, her book, Undoing Drugs, which is one of the histories of harm reduction, is what she said. And she said, and she is a person with living experience. She said it was mainstream to see people who use drugs as worthless, disposable, and deserving of every horror, including AIDS. It wasn't just that people like me weren't being told how to stay safe out of indifference or because of other spending priorities. It was much worse. The information was being kept quiet on purpose out of fear that letting us avoid AIDS might possibly encourage future children to try drugs. We were useful to suffer and die as bad examples. So again, that is, a really powerful quote of her experience. And so just to reiterate, harm reduction is multifactorial, it is multifaceted, it is multicultural, and it is very multidisciplinary. I love this picture because it is the founding picture of those, and I think it's from 1993, with the Harm Reduction Coalition that they eventually formed. There's a whole history around the Comer Foundation. So these were very affluent individuals from the Land's End, whatever marketing or company, Land End Company, which is a high-end clothing store. And the Comers had friends who had HIV, and they were really concerned about how people were being treated. And that intersected with the intersection of injection drug use. And so they really were kind of the founding monetary supporters of the harm reduction working group that you can see here. And as you can see in the quote, the group was diverse, but everybody had one central point, which was to do something to prevent the spread of HIV and AIDS. And certainly in that era, and I know Nancy and I have talked about this, that in the early 90s, if you knew people that were using drugs, you also saw AIDS, the face of AIDS and the face of HIV, and you watched your friends die and wither away. And so there was just this outrage of what can we do to help keep people alive. And so I want to also show these principles of harm reduction. These are on the website, you can see here. And I just want to kind of walk through them for us. There are 8 different principles that have been defined. And so the first one accepts, for better or for worse, that licit and illicit drug is part of our world, and choosing to minimize its harmful effects rather than simply ignore or condemn them. Second principle understands that drug use is a complex, multifaceted phenomenon, and it really encompasses a continuum of behaviors from severe use to total abstinence, drug-free status, and acknowledges that some ways of using drugs are clearly more safe than others. Third, the principles establish a quality of individual and community life and well-being that aren't necessarily the cessation of all drug use. It really puts the criteria for successful interventions and policies. Number 4 calls for the non-judgmental and coercive provision of services and resources for people who use drugs and the communities that they live in to assist them with reducing the harms. Number 5 ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation and programs of policies designed to serve them. And that was something that was so important with sort of the the way that people were finding themselves excluded from treatment or or removed from treatment, it really became a movement of nothing about us without us. Number 6 just affirms that people are using drugs themselves are as the primary agents of reducing the harms of their own drug use, and seeks to empower them to share information and support each other. And again, you could hear that in Maya's quote, right? That there was a perception or a feeling or that the information was deliberately being withheld from people. And then number 7 recognizes the realities that intersect with substance use disorders and how we treat that, with poverty and class and racism, social isolation, trauma, that sexual, physical, and/or emotional abuse, sex-based discrimination, and other social inequalities that affect people's ability to deal with drug-related harm. And then finally, number 8, which says that the principle does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. And I think in this age of fentanyl, we are learning so much, and the way that we work, often needs to be modified in order to be able to best respond to the poisoning of the drugs that are out there. And so I want to end with sort of 2 examples. I think that when we think about harm reduction, that we cannot do harm reduction in isolation, that absolutely it must be situated and nested in a continuum of care. To give an example, when we have people that come to drop-in centers and they're there to receive food and to receive social services, to receive medical care for their wounds that they have received from injecting drugs, being able right then and there to offer treatment, to say, we can start you right now on a medication to treat your opioid use disorder. Would you like that? And if they say yes, absolutely. We have many examples that I can share of people that have come to drop-in centers that are ready for treatment. They want that treatment, and we get them, through a bridging program that same day to start their first step on their treatment recovery, which can be that buprenorphine, to help stabilize their brains and help give them a platform for stabilizing their life. And then I also have seen the examples of when harm reduction is done completely in isolation, where we were relying only on the exchange of maybe 1 or 2 needles for another needle. And I actually had the occasion of seeing somebody in a needle exchange program that said he wanted treatment and was ignored. And that is harmful. So as we have our conversation, I know there are many opinions and beliefs and views. So let's just make sure that we have really good ground rules for listening to each other, for being accepting and sort of suspending judgment, so that we can make sure that we're having that great communication about these different practices. And thank you so much. And I'm going to turn it to Michael to lead us through our questions for discussion.
Michael, is Michael muted?
Michael,
or?
are you muted?
Thank you. Sorry about that. I was trying to be respectful, and I've muted myself. But I'll start again. So first of all, thank you, Dr. Jones. I really appreciate the presentation. And, a number of us were talking before the presentation and how many of us who've been involved in this work for a very long time, even many of us who've done HIV and AIDS work, were really unfamiliar with all of the history here. And I think if we want to know where we are, we have to know where we've been. So I really appreciate it. Let me just reiterate what Dr. Jones said in terms of some ground rules here. This is, by kind of full admission, this can be a really sensitive and controversial topic for many, many people. And so I want us to really hear each other and to respect people's opinion around this. So I always take liberties as a facilitator. And I want to kind of start by just asking Dr. Jones a follow-up question. And you are kind of uniquely, I think, situated as a physician to kind of answer this. So how do you see the principles? So our understanding of addiction as a chronic condition, and our formulation of our services to meet that understanding, how do you see the principles of harm reduction in this context play out with other chronic conditions? So is this how we, in essence, kind of think about how we might engage people with other conditions? So where does this match how we deal with other chronic conditions, and where do you think it differs?
Yeah. Well, first, I'm not a physician, but thank you for the elevation. I'm a PhD.
I did. I always thought you were.
That's so funny. I know. I say that I can speak like OB language, but yeah,
Yes.
I'm a psychologist. So just to put that out there.
My
So
apologies.
maybe we should go back to the principles just to put them up. I can do that. Oops. Now I don't know what happened to my screen. Hang on a second. Let me stop sharing for a sec, and then put them back. So, oh, that's so weird. What did it do? I don't know what it did. Hang on. It's like completely black for a moment. I don't know why. Well, I guess I don't get to do that. So yeah, I mean, I think if we think about substance use disorders as a long-term chronic condition, one of the things that we don't want to do that happens so often is a short-term acute approach to care. And so often we see what happens is, we have somebody that has a substance use disorder, they go in for a 3-day withdrawal from their medications, they get stabilized into a drug-free state, and then there's like, what's the next step, right? So often our types of care are really siloed, so that if you do go in to that detoxification or assisted withdrawal, like, we don't connect people to services in the next way. And I think sometimes with other chronic conditions, we also don't do a great job of connecting people to services in the next step. I mean, let's think about diabetes, right? We have a wonderful medication of insulin, and that tends to be the focus, right? Is how's your insulin, how's your sugars? But there's less emphasis on talking about all of the other life factors that go into it. How often does your physician really talk to you about nutrition? How often are you given nutritional, consultation? And in part, it's our medical model, at least in the United States, we get paid, physicians get paid, medical providers get paid for doing things that they can control, rather than that more kind of consultative counseling approach. And I think too, when we think about diabetes or hypertension, there is sort of more of a free pass. We don't expect perfection. We expect progress. And I think sometimes for individuals that have substance use disorders, everyone wants a cure. Everyone wants, like, oh, someone's gonna go to treatment and then they're gonna be good, and then we don't have to worry about it anymore. And we know that for so many people, that journey is very undulating. And so I think that, the idea around the principles of harm reduction, it does meet people where they are. It accepts that there might be a return to use, doesn't always have to be a return to use, but that is something that is there. And there's also, we're not going to ignore you. We're not going to drop you off. We're not going to have treatment or a process, something that is done to you. It's really done with you. So I don't know if I really answered your question, but those are some thoughts.
I think that's really helpful. I think that, kind of the point that you're making here is that, kind of the principles of harm reduction kind of transcend just HIV risk issues and addiction treatment. That in fact, that's in many respects the principles that we use to kind of think about approaching people with other chronic conditions, right? So I want to kind of return here. I want to open this up and kind of start with the questions that Dr. Jones kind of is posing to the group, and just ask folks just to please raise your hand in the Zoom. So I want to start first by, these, unfortunately can often be seen as kind of polarized principles or polarized set of services. But I want to ask folks the opposite question that Dr. Jones posed, is basically how do we see, or how do you see harm reduction and recovery working together? And if you have, I think, particular examples of, how you have seen that in your own life help people, we'd love to hear it. So how do people see kind of harm reduction and the recovery world working together? So let's start there.
Stephanie Short has her hand up. Has their hand up?
Great. Go ahead, Stephanie.
So, Stephanie, if you're speaking, you're muted.
Oh, no. All right. I have it. I'm just wondering why my camera's not working. But anyway, so I'm a person with lived experience. I was a drug addict and alcoholic for a really long time, and I've used harm reduction. I'm from Wisconsin. And so like when I was using and became an IV drug user, I would have to travel like 50 minutes to get to a needle exchanger where I could get those, because I live in a very nice small community where there's none of that. But that was like the extreme end of it. But now I'm a peer support and a recovery coach. I've been clean for 5 years, and the way that I look at harm reduction now, I feel like that's more of the extreme, more of like an extreme end. People are in pre-contemplation. They're not even thinking about recovery, but are still being safe about their drug use. That's what I did. They would actually load me up with grocery bags full of needles and stuff because I was also dealing drugs, and I would hand those clean needles out with the drugs I was, so I was kind of being like the safe drug dealer, I guess. I don't know. But when it comes to harm reduction where I'm from, because like I said, I live in a small community, is that and it may seem, to some people like, why would you even do that? When it comes to harm reduction, I'm like, how do you feel about not doing fentanyl and maybe switching to marijuana? You know what I mean? Like doing, like phasing down out of, you know what I'm saying? Like phasing out of like the hard drugs, because like you were saying with fentanyl, that's even more scarier. It's, or handing out the the nose thing. I can't remember. I don't know why I can't think of the
Narcan?
Narcan, handing Narcan out, and that's another thing that we do. Our community is putting up Narcan kits in bars, gas stations, like places where people would normally that may be on those, and that's like my daughter works at a smoke shop and they have Narcan and fentanyl test strips, but she also then, this is really funny, has my business cards there too, saying, recovery coach, peer support, for when people are coming in that way. So I guess kind of having those things like you're saying kind of put together, like I have people reach out to me all the time because I have a contract with Department of Human Services asking for help, and I'm like, well, what are you doing? Do you know about harm reduction? Like all the things, and trying to help them get into services. So I do a lot of stuff obviously for free, trying to knowing that they're still using, but trying to help them along, the path to be able to get into recovery. So I use both, I'm kind of in that middle ground. Ultimately, I'm like, I'm clean, I don't drink, I don't do drugs, I don't smoke pot, I don't smoke cigarettes, I drink decaffeinated coffee, you know what I mean? So like, but I'm not one of those where it's all like, it's complete sobriety or nothing, you know what I mean? So I guess that's where I am, because if you can just tear them down instead of taking one huge step right down to recovery, you can be like, here, harm reduction, get them from pre-contemplation into contemplation, maybe to preparation, using that trans theoretical model of, and just info, the harm reduction all in the beginning stages, and then walking with them through the rest if they want to.
Great. Stephanie, thank you very much for kind of sharing your story here and your experience with that. And I think, you know, kind of you right on the front line, kind of, I think trying to undo some of the misunderstanding at the community level around harm reduction is really critically important. So really, really appreciate that. So Landry, you have your hand up.
Yes.
Please go ahead.
Thank you so much. First of all, I would like to thank you very much for this great opportunity to attend this meeting. I'm Landry Woodраgo from Burkina Faso. I'm the URC Global Master Trainer of Colombo Plan. And in my country, Burkina Faso, what we noticed that harm reduction play an important role in the process of recovery. Why? Because it's really help to avoid health complication. We really think that recovery without harm reduction is not enough. They have to work together in order to help fully those who are in the drug abuse disorder. So this is my point. Thank you so much. Thank you so much.
Great. Thank you, Landry. I think it's speaks volumes in terms of how you have kind of integrated and understand that harm reduction is kind of another tool in the toolbox here, right? And that we have to kind of engage and meet people where they are with it. So thank you for that. Joe Vanderberg, looks like from South Africa. Joe, you might be on mute, so
okay.
if you're speaking.
Sorry. Hi,
there
good
you
day,
go.
Michael. Can you all hear me?
Good day.
Yeah, I just want to share the view of South Africa, especially the rural areas, about how do they see harm reduction and recovery working together. I think our people is very uneducated. Because they do not believe actually that the person can still continue using even though the person is cutting down on its substances. So it's quite a challenge. My personal view, I can see how it works together, recovery work together, because I think it's a process for the person to become addicted, and it's also a process for the person to recover. But yeah, as I said, it's quite a challenge here in South Africa, and especially in our rural areas, for the people to understand why we sometimes have to go the harm reduction way. Thank you very much.
Good. Joe, let me follow up with you. A number of folks have mentioned kind of the misunderstanding and lack of education. So how do you deal with that? Or have you seen strategies that you think are helpful at the community level to kind of educate folks around harm reduction and dispel some of that misunderstanding? Have you seen some things that work?
Luckily for me, I went to a 3-day training in Cape Town once of the UN about harm reduction. But what really worked is the harm reduction support groups, actually. To gather people in active use together, and then they actually know, okay, they can still share about their obstacles and all those kind of stuff. And later on, you will see that they will actually enroll into the program because they feel that someone is understand their point of view. At the end of the day, they can't just stop using. And like my other colleagues said earlier about, okay, I was using methamphetamine, so now let me then rather use cannabis instead when the craving comes. And it's causing less harm at the end of the day. And they're more functional.
Good. Good. Thank you, Joe. Up next, we have Fatima. Just a reminder to unmute your microphone.
Can you hear me?
Yes, we can hear you. Thank you, Fatima.
Okay. I want to explain that in Nigeria, about 5 years ago, harm reduction, because it is seen as an act that is enabling a drug user to continue using drug, especially by providing the needle. There are a lot of awareness creation, sensitization. The public is enlightened, the public is educated, and the government is educated also that harm reduction is very important. So now in Nigeria, about 7 states out of the 36 states have implemented the needle and syringe program. So linking the harm reduction to recovery is very good, because when people are in recovery and they have to use their medications, it is important to allow them to do it, because like we always say, not everyone that is using drug will want to stop. So for those who do not want to stop and we want them to be protected, there is need for the needle and syringe program to continue, so that it will sustain them and it will protect them, from getting into other diseases or from getting infected by other diseases. So I think that the linkage between harm reduction and recovery is very important, and it is also very possible. And I'm happy that in Nigeria, the needle and syringe program is now being implemented at least in 7 states. And as time goes on, it will extend to other states. Thank you.
Great. Thank you, Fatima. And it's good to hear that there's kind of been progress on this work in Nigeria. And I think everyone would agree that kind of, not seeing these two things as separate and distinct is really critical. And kind of your point about ensuring that kind of harm reduction and recovery are linked, I think can go a long way, particularly as you said, to kind of dispel this myth of kind of harm reduction as enabling drug use. So thank you for sharing that. Next we have, and it looks like a screen name, is Techno. So if you want to kind of introduce yourself, and love to hear your questions or comments. Can you hear me? Techno, do you want to go ahead? Can you hear me?
Techno is muted. So if Techno wants to speak,
Techno, I think
Techno
you're
needs
muted.
to
Can you hear me?
unmute.
Okay, well, let's come back to him, see if we can get him. Anne, Matthew, do you want to unmute and ask your question or make some comments here?
Hello, good evening. Yeah, my name is Anne from Kenya. You can hear me?
Welcome. Yes, we can, Anne.
Yeah, my
Thank
name
you.
is Anne. Yeah, Anne from Kenya. I'm a recovering alcoholic. I'm 18 years sober. And from what I can see, and is that from what I understand, I haven't had any training in harm reduction, but I tend to believe that harm reduction and recovery go very well together, because I tend to believe that harm reduction is the first point of contact with a person with SUD, and it is the first point whereby this person feels loved and appreciated, where he feels understood, because I believe people with SUDs are misunderstood population who need love, who need affection, who need to be listened to, who need to be taught, who need to be talked to, who need to be close to us, who need to be embraced, to give them hope that recovery is possible. Thank you very much.
And thank you. That was really beautifully said. And I think it's a great reminder to all of us in terms of how we kind of engage here. And I just want to say, a number of people have mentioned, which I think is really important, that kind of getting kind of people with SUD, that to get to recovery, it's a process of change. And it doesn't happen overnight, and people go through stages. But continuing to engage with people and as Anne mentioned, with love and respect and with hope, I think is really important. So thank you for reminding us of that. I want to go next to Warren Cornelius from South Africa. And this is a nice point that actually Warren is going to be our next presenter at our April 11th dialogue on what he's been doing, he and his colleagues have been doing in South Africa to reduce stigma. So with that plug, Warren, I'll give you the floor.
Thanks so much for that introduction, Michael. I'm really enjoying this presentation and this. So harm reduction is really a pathway to recovery, isn't it? Like a pathway, a recovery pathway. And I think in my setting, in the South African context, and somebody alluded to it earlier on, I think Joe spoke about it, is that there's a misunderstanding of what harm reduction is. In actual fact, the problem is we haven't defined recovery actually. So people don't know the definition of recovery, and the definition of recovery in South Africa is really abstinence. And when I heard the presentation and I've seen that the definition of harm reduction is very similar to the definition of recovery. It's really a personal change, positive change that we make, and it's kind of the same thing, isn't it? And so we often think of harm reduction in my context as a needle exchange program, or it might be a substitution, medical substitution or something to that effect. Suboxone and methadone or whatever, but actually what it is, and what I loved about what the speaker was speaking about earlier on was the saying that it's about acceptance. We're speaking about love and respect and all these things, and above all of that, it's actually just acceptance, really. If like I'm also someone in recovery, and I can tell you that shame and guilt are the biggest drivers of substance use and how we feel about ourselves, really, eh? And what happens is it's not only from a needle exchange point of view, but also from a therapeutic perspective. Harm reduction is really about somebody coming to you and they're trying to stop using, but it's not about like abstinence. It's about, hey, you've managed to last a week without drugs. How about trying for 6 days? And just reducing the time, the length of time between relapses. That's also harm reduction. And even in our engagements with people, just accepting them for where they are in their recovery process, that's harm reduction. So it has a negative connotation in South Africa by a lot of treatment centers and a lot of, I mean, the general public, just because they don't understand what harm reduction really is. And it's just for us really to live out this acceptance of where someone's at in their own recovery. I come from a 12-step background, group background, where it's also really abstinence based. But and I've seen people relapse and spend their entire lives relapsing, and perhaps they would never find abstinence. But if we had just been more accepting of people where they're at, they would have been more likely to succeed on their journey, whatever that might be, or whatever that might look like. That's kind of my take on this harm reduction. And I think I touched on your point too as well about how it helps people find the acceptance of people for where they're at. It's a motivation, because guilt and shame is the biggest driver of relapses. Yeah, that's my take on it. Thank you.
Warren, thank you. I'd like to make a kind of follow-up personal observation too, that I found my recovery through a 12-step program, and this might be a little bit of a stretch, but I always say that AA was one of the original harm reduction programs, and if you understand the principles of Alcoholics Anonymous in its preamble, it said the only requirement for a membership is a desire to stop. It doesn't mean that people have to stop. If people relapse, they're not kicked out. And so we often, I think, mix up kind of principles for personalities here, but Alcoholics Anonymous is a very welcoming program, regardless of where people are. Let me also ask you a follow-up question. One of the principles of harm reduction that Dr. Jones articulated was this inclusion of people with lived experience as kind of part and parcel of service delivery and provision. Have you seen that change in South Africa? Have you seen that becoming the norm where people with lived experience are really included as part of the decision-making process or the feedback of service provision. Has that changed? That was to you, Warren.
No, it hasn't, not as yet. Yeah, so it hasn't changed as yet. I don't know if you can you hear me?
Yes.
Yes.
Okay. Yeah. So that hasn't changed as yet, and
Oops. I think, Warren, you're kind of breaking up a little bit. You kind of froze on us here.
all these so you'll find treatment centers and different organizations really, yeah.
Okay. Warren, we kind of missed you a little bit here, so I'm just going to kind of move on here. You know, I'd like people's reflection on that too. Is, you know, that's a kind of core principle of harm reduction. And as you know, Dr. Jones said, nothing about us without us. And I'd love to hear people's reflection on whether or not they see that kind of attitude being incorporated as part of the kind of addiction treatment and recovery world. So, Mercy, you have your hand up. Please just unmute yourself. There you go. Thank you. Go ahead, please.
Hi, good evening from Kenya. My name is Mercy. I work in harm reduction, specifically in an OST facility. So what I would like to say is harm reduction is not only in recovery, but it is part of recovery. Because seeing from our patients who come in for OST, it is through harm reduction that patients get the motivation to stop their substance use or their drug of choice. Then at the same time, they start their journey of recovery. So to me, I believe that harm reduction is the initial stages of recovery in our patients. Then maybe also looking at the other question that you've just asked of lived-in experiences, where the slogan is nothing with us, nothing without us for us. In our facilities, we have peer-led programs whereby we have peer educators who work as a link of the people who are still in the dens using opioids, and at the same time linking them to care and bringing them back to the clinics. If we have lost to follow-ups, we go through the peer educators, that is the people who have been in the dens with them, and they are able to go back to the community and reach out to them. So we also have other programs that are peer-led, because we feel like those people who have lived the experience are in a better place to draw in more people into the program for recovery. Thank you.
Great. Thank you, Mercy, for sharing your experience, and thank you for your work here. Just at this point, if folks have comments or questions, please raise your hand. Dr. Jones, do you have any reflections on or observations on the conversation so far?
Yeah, so before I give any reflections, I just wanted to make sure that we elevate what's in the chat. There have been some really nice comments in the chat. So, Michael, I don't know if you want to read them or you want me to, but there were just some...
Go ahead, Hendrée.
Okay, yeah, so let's see. We had, is it Jism? Said that their opinion is, even though as medical professionals trying to decrease the harmful use, trying public health promotion for harm reduction, but if the most popular singers and actors are openly consuming active drugs, youth follow them, not the professionals. And I think that just really, you know, messaging is in social media and who our role models are so incredibly important. And I always really appreciate when we have stars that are openly in recovery and talk about being in recovery and promote recovery. So while we do have people that openly consume, we also have people that that also promote recovery and how powerful that can be. And if there is a return to substance use, people love a good story, right? So that idea of being able to triumph, I think, is really important. And then there's a long one from Roddy. And Roddy answered all of our questions
That's
in a
great.
very
I know.
way, which is wonderful. Thank you. So Roddy, I don't know, did you want to say anything else about what you had put in the chat? No, maybe not. Okay, so Roddy said that they believe that harm reduction, has to do with a better understanding of the needs of users, providing them with continuous care without discrimination, right? Without requiring total abstinence. Oh gosh, it's hard to read. Since each one will have their own unique goals and own vulnerabilities. So again, representing that person-centered focus. There's a great example of in 1988, right? They lived in Barcelona and the kids came and they were using HIV, or they were using and they acquired HIV. And they remember that some pharmacies began to give away syringes, and there were people who went to the points to meeting and consumption to bring medicines and food. So again, it's that idea of a holistic approach, and harm reduction being sort of the initial starting point to bring people into recovery. And then they didn't have any worries or concerns about harm reduction. It only had positive effects.
That's great.
Yeah.
And
then
Andre,
Techno also provided a comment because we didn't get to hear from Techno. So yeah, go ahead.
No, I think it's interesting that in many respects, a lot of programs that are now kind of sanctioned and funded often started as very underground efforts at the community level as a response to this. So, naloxone distribution, for example, is really kind of part and parcel of our kind of repertoire of how we deal, particularly with the kind of opioid crisis here. But that started just like a lot of syringe service programs and kind of clean needle kits started as underground programs. And so it's really kind of this evolution from an underground movement really to more mainstream services that I think is really interesting kind of arc of these programs. So thank you for that. So this is very nicely coincidental. So Boro Garg has his hand up, and just Boro is actually going to be our May presenter, talking about a topic that was of great interest to people in the network, and that's about how to form a network and the work that he's done with the Run network. So with that intro, Boro, go ahead.
Yeah, thank you, Michael, and hello to everyone. What an interesting topic. Let's say like this. An hour is not enough. Hopefully we will see each other sometimes in person and then talk more about that. Okay, it seems like when I hear the people, it seems like harm reduction and recovery functioning almost perfectly together. But I would like to raise a little bit my concerns about harm reduction and what I saw in my practice until now. So when we talk about harm reduction, we agree, everybody, that we are talking about needle exchanges, so reducing of harms with the blood-borne diseases, and of course, methadone and buprenorphine programs. The problem sometimes, it's really when we from recovery organizations, I'm not speaking now only about drug-free programs, I'm speaking about recovery organizations that are really wanting that people are reaching some kind of their full potential. And we are coming and start to talk with people from NGOs who are dealing with needle exchange or people inside of institutions that are giving methadone. We see that we have a different therapeutic goals. So what does it mean? Basically, if we have different goals for one person, then it's very hard to work together inside of that. This was a concern, that I raised already 15 years ago. And I think maybe that in the last few years, we came to the ground where we need to sit together and really not to think to work together and then to deal with the different therapeutic goals, then to really see what do we want with the drug users. What do we want with people who are in methadone programs already for years? So basically, this is one kind of concern. My other concern, it's where is how started harm reduction? It's very clearly. That was very good about HIV and everything. My problem is where harm reduction will end. And all that radicalism that is built with the harm reduction programs. For example, we started with the needle exchanges. Do we need needle exchange? Of course. Who is against? Of course, that maybe in some parts of the world, there are no recovery programs existing. If we want to do something with the people, we first need to save lives. In Karachi, in Pakistan, if we don't have a clean needle, people will all die. People will get HIVs, etc. So basically, we need harm reduction. But then it's the next question. Do we need shooting galleries? It's a part of harm reduction program. So then it's the next question. Do we need a prescribed heroin? So this is the questions. And what is the next? Everything is okay. It's just a question. So when we go a little bit back, there is always a question. Okay, the harm reduction is built among a huge heroin abuse. The heroin in Europe is going down. You know, so all the reports are showing that. So what is the harm reduction in the way of methamphetamines, amphetamines, cocaine users? And why do we still speak so much about harm reduction measures in the way of all policies? And why harm reduction measures are so much funded? Vice versa, recovery programs that are not so much funded and that we need mostly in Europe, so much cuttings and closing of programs, closing of therapeutic communities. So everything is questionable about that. So basically harm reduction, yes. And I saw some of programs that are combining when you speak with the people, when they are coming to drop-in centers, people from harm reduction are offering some kind of recovery services. Of course, not when they see the person first time, then after they develop some kind of relationships. And I think this is good. But most of organizations, when you start to speak with them, harm reduction organizations say, okay, we are not providing that people want to change. We don't want to provide that kind of services. And I'm afraid of that some harm reductions organizations a little bit changed, you know, so they don't want to see people change. They don't want to see people developing in their process, however we call it. And then it's very hard to develop some kind of together work. I saw it in Barcelona, some good ways of cooperation. I saw it in Croatia, some good ways, but who started those harm reduction programs? I must tell you, those people who were in recovery. So people in recovery started the drop-in centers, and then because they approach is a little bit differently, so they started to approach people and trying to deal with them into the recovery process and potentially drug-free life, if no, then some kind of acceptance, etc. So I think dichotomy, harm reduction against recovery, it's not good. We need to sit together with everybody and to be a distance from that dichotomy, because it does not bring anything. From other way, we need to sit together and really to see what do we want with the drug users. Do we want to give them still drugs? Because some people who are speaking about, like Neil McKegney, I don't know who read his books, said that harm reduction is Trojan horse of this what we have together, and this is legalization of drugs. So maybe I was too, sorry, but this was my concern about everything. Thank you.
Good. Thank you, Boro. And we're just about out of time. I will reiterate that kind of Boro's kind of two comments, which I think are kind of an apt wrap up here, that an hour is just kind of scratching the surface, and there are lots of questions. But I think you ended on a really telling note here about how we sit together as kind of one community and begin to think about kind of working together, collaborating together, creating some common goals and strategy. We can't do this work in isolation. we can't talk at each other. We have to talk with each other. And I think it's only in that spirit and with that emphasis will we kind of make progress and begin to bridge some of those gaps. I again just want to thank Dr. Jones and as well as Nancy and Ashwin for putting this together, and give the opportunity for Dr. Jones to see if she has any kind of final comments here.
Well, before I do, I wanted to give it to Nancy just for a sec. Nancy, was there anything that you wanted to say? Because I know you're very passionate about this topic, and I wanted to give the floor to you.
Okay, thank you. I am so glad that we opened the door to this very controversial topic. I think we've all learned something by sharing and listening to each other's perspectives. I know I have. I do want to say one comment. I have never been a fan of harm reduction, and I've been in recovery from hardcore addiction for 38 years. I'm changing my understanding of what harm reduction is, because one of the principles that I live by in my recovery process is open-mindedness. So I want to have an open mind to the experiences of others. Where is the good to be found? What are the limitations? I have many reservations that harm reduction, while it meets people where they are in many instances, can be a destructive force. That said, I also believe, bottom line, harm reduction can save lives. It can lead people into treatment. It can lead them into recovery. And it's all dependent on one thing. What is that one thing? That one thing is the quality of training and understanding of what a substance use disorder is, what recovery is, that it's a miracle, it's probable and possible. And probably the most important thing, what is the value system of the individuals providing harm reduction services? Is it built on acceptance, love, helping individuals out of a world of isolation and darkness and shame and guilt? Or is it built on, gee, this is going to keep my funding going, and the more I have people showing up needing needles and needing the more desperate the patients, the more my harm reduction service clinic can thrive. So really, we really have to ask the best of ourselves when we are engaging in these services. And I think that it's not only what services are provided in harm reduction or in the name of harm reduction, but in what spirit are those services offered? And I think that's what we really have to ask ourselves. And as individuals, as providers, as professionals, and as a society, do we want to save lives or do we want to isolate and punish people? You know, it's kind of one or the other. So thank you for letting me have that final word, Hendrée, and thank you for leading us, and thank you, Michael.
Great, thank you, Nancy. That was beautiful wrap up. Really well said. Just a couple kind of housekeeping things as we wrap up here. We'll be sending out a summary of today's dialogue. So I want to kind of thank everybody for their comments and their participation, both through the chat and verbally here. So we'll send that up. As I said, our next dialogue will be April 11th, and Warren Cornelius from South Africa, who joined us today, will talk on some of their work around reducing stigma, which is really a kind of popular topic here for our network. And that invitations and reminders for the event will be sent out to all registrants. So we hope to see you all next month. And again, I want to thank Dr. Hendrée Jones for kind of kicking us off here and for a really engaging presentation. So thank you very much, everybody. Hope you have a great rest of the day. Thank you.
Thank you, Michael.
Thank
Bye,
you, everyone.
everybody.
Thanks for showing up. Take care, everyone. Be well.
Bye. Take care.
Thank you.
Bye-bye.
Bye-bye.
Keep hope alive. Keep hope
Right.
alive for recovery.
Thank you so much.
Keep
Open
coming back.
energy.
We need you.
Compassion. Bye.
Keep saving lives. Thank you.
Bye from Kenya. Bye bye.
Bye, Anne.
Bye.
Bye. Bye, everybody. Take care.
Thank you, Dr. Jones.
You are welcome. Thank you, Nancy. That was beautifully said. You said everything.
Yeah, nicely said.
There's nothing else I needed to say. I knew you were going to do that. It's just perfect.
Hendrée,
my goodness.
Hendrée, I apologize that I didn't get your credentials right.
Okay.
You talk a good game, right?
Right, exactly. I speak MD. What can I